point, one of the key things that we are really worried about was to ensure that we prevent further importation of cases. And the measures that were taken at that time, including, of course, the earlier very wise decision by His Excellency, the President, closing down the schools, were majorly to, avoid the rapid spread of the disease once the disease had gotten imported. During this time, of course, we locked down the airports, we closed the borders, and we instituted a partial lockdown. I call it partial because a lot of people imagine that we had a full lockdown. But during this lockdown, we allowed people to walk. We only stopped the cars from moving, except the cars that were for essential workers. We also instituted a curfew. And of course, in the process, we intensified contact tracing and surveillance. That was done, of course, over a period of time. You saw us running after truck drivers left to right to make sure we test the truck drivers, we test the people who are returning from the airport. And all of these were either, we were quarantining them and making sure that the contacts that they had come in touch with, we would trace them and put them into quarantine. But that did not stop the subsequent emergency of sporadic cases in different places. And this is now the second stage. And we got to appreciate that we had actually moved from phase 1 to phase 2 through the rapid assessment surveys that the Ministry of Health was running. And this was quite very strategic in terms of understanding how widespread the disease was across the community. At this time, of course, what we were doing is still intensifying the cases. I mean, the case tracing case finding and contact tracing. And then, of course, we moved on to stage 3, where we began seeing clusters of community transmission occurring in Chotera, in Gulu, and Kampala. And subsequently, of course, now we are in a stage where we have established community transmission. But the viewers need to understand, why did we lock down the country in the first place? At that stage, the key thing here was to, number one, prevent the importation of cases, but also build capacities for care and response. And behind the scenes, one of the things that we did quite efficiently and effectively was to make sure that we had capacity for laboratory diagnosis of the disease. We had capacity for case management. So far, Uganda has expanded the laboratory testing framework for COVID-19 from just UVRI to different laboratories that are located across the country. Of course, including CPHL, Makerere, Gulu, Tororo, and we have labs literally spread across the country. But in addition to that, we have activated private laboratories that are doing the testing. We built capacities for care. We made sure that we set up intensive care units in every regional referral hospital with about 10 bed capacity. At the same time, we made sure that the district hospitals had an area designated for COVID care. And we activated the district task forces led by, of course, the DHO, but involving the RDC, involving the MP of the region, and also involving the DSO. And at the same time, of course, we intensified our capacities for surveillance and contact tracing. But most importantly, we set out to communicate the risk that COVID-19 posed. And at that time, of course, you kept seeing us come here with the minister, and the president would speak much of the time to make sure that the Ugandan population had information about the disease, but also appreciated how the disease is spread and what can be done to stop the process. So at this stage where we are, the strategy is different. It is no longer about preventing the importation of cases because we have so many. Yes. So the most important thing now is to mitigate the impact of you know, having all these many cases. We know very well that COVID-19, when it attacks, not everybody will experience severe disease. About 85% of the people that are exposed to the virus that causes COVID-19 will be asymptomatic. The other about 10 will be moderate to mild to moderate, a few symptoms. But there's a small group of 5%. That's the group we keep worrying about. Unfortunately, none of us knows whether we fall in the category of the 5%.
And you can't choose, actually.
Exactly.
You can't choose what group to fall to.
Yes.
Or under. Thank you. Professor Roda, let me just come to you. And now that Dr. Misaki, the chairperson, has highlighted to us the situation and, of course, where we came from, we overheard the president all the time that he spoke to us talking about the flattening curve, flattening curve, flattening curve. And I think we are no longer on the flattening curve. The thing could have gone there. But now that we are in what you call stage 4, let's highlight the dangers of where we are, and I think what we need to do currently and right now. One of the things that we're trying to do is to adhere to the SOPs that you designed, or originated, or started for all of us. How are we working? How are we performing? And in a situation where we are, and at this particular stage, what do Ugandans have to do?
Thank you, Jagenda. So to start with, Uganda managed the pandemic very well to start with, and you might have heard the minister talk about Uganda being number 10 across the world in terms of managing the pandemic. So since March, we went through the first 3-4 months with fairly low numbers, and it took us quite some time to build to the first 1,000. But since then, the numbers have been growing. Our first small peak started around August. The numbers started going up around mid-August. We started getting concerned. The numbers were going up, and then they came down a little bit. But since September, we have been seeing a very rapidly growing peak. We are really worried. The curve is virtually pointing directly to the sky. It's going up each and every day. The numbers are not good. So, and like Misaki explained, we are now in that phase where we can hardly track where people are picking this infection. That stage 4 is very dangerous. It is dangerous because at this point, the infection is widely spreading within the community, and it's reaching out to the most vulnerable people that are likely to get very severe illness. And it's no wonder we are now getting very severe disease and people are beginning to die. So as we speak, we've now gone over 26,000 cases in Uganda. We have 220 deaths. But one thing I need to emphasize is that actually these numbers are an underestimate. So if in case you're thinking 26,000 is too small, and 220 deaths is too small, I need to emphasize that the 26,000 is an underestimate, because when you are testing people largely based on those who have symptoms, and they are calling to say, I have fever, I have cough, I have flu, then you're picking the tip of the iceberg. That's about the 20% that he's talking about, because the majority don't have symptoms and they will not call to say that they have disease. So perhaps we have many more people who are infected out there. What that tells us is that we are not safe wherever we are. We are in a meeting, you are at a wedding, and you have gone to a funeral, you are not safe where you are, because there are so many people who are infected out there. And as the infection penetrates further and further, then we are reaching our old people. And we are going to do a lot of that over Christmas when we begin to go to the village to see our parents. From Kampala, from Wakiso, where there is a lot of infection, we are now going to move to the villages for Christmas, for New Year. We are actually going to take the infection to other people, the older people, the people that have underlying conditions that are likely to get more severe disease. And as it penetrates into that category, then the deaths begin to go up. Right now, our case fatality is about 1% among the confirmed cases. The deaths are about 1%. But this percentage will perhaps go up like we have seen in other countries for two reasons. Because as we continue with spread in the community, the likelihood of getting these people who are likely to get more severe disease increases. We get in more of them. But then at the same time, we are also overwhelming our system to provide care. So right now, as we speak, that system is overwhelmed. We don't have beds. The people that need critical care can't find beds. If I fall sick today, myself, I might not find a bed if I need critical care, if I need ICU, because it's full.
Okay.
And they're not going to remove someone else so that they give Rhoda a bed.
Okay.
And that is the same for all of us out there. So we are overwhelming our system, and because of that, people will die because we can't provide good care.
Thank you, Professor Rhoda.
Yeah.
To you, Professor Kalebo, you are at the UVRI, and of course, you're in charge of the testings and doing all the things. Professor Rhoda here says, of course, the numbers that we talk about are an underestimate. What's the picture? What is the reality there when it comes to testing itself from what you have done so far, giving us and painting a picture? Because yes, when you talk about 26,000, people will say, but you talk about 26,000 out of 40 million Ugandans. When you talk about the death toll, which is only 220, for example, today, and we'll say, but you talk about only 220 people of this whole whooping population of 40,000, it doesn't seem so threatening or worrying or scaring as it may be. Give us a true picture of what you've done so far, especially when it comes to testing. And of course, let us also know, is it possible to at least test every Ugandan or all of us to be sure that here is where we are and here is how we're going to manage the pandemic?
Well, thank you very much, Chair. Just as all my previous speakers have mentioned, I think what we're talking about, the numbers, is an underestimate. We have not tested everyone. In total, we estimate the country has conducted about 650,000, approximately 700,000 tests since the pandemic. So that's low number. It's a low number. And our positivity rate is about maybe approaching about 10%. So the numbers tested, it's because it's expensive to test everyone. The procurement is not that easy, but Uganda, I think we have made an effort. As Dr. Misaki mentioned, we started testing at UVRI in February. The first case was March. UVRI was the only testing lab for 2 months. We expanded Central Public Health, Makerere University, other labs at the border, mobile labs, then the private labs came on testing. But because the testing is expensive, the ministry changed and said, okay, now we're going to test those who are symptomatic and contacts of symptomatic, frontline health workers, and some of the survey. Those who want to just check by themselves or traveling, they should pay privately. And now, as you're hearing, a lot of the people we're seeing are symptomatic. There are many asymptomatic people we are not testing. So the testing is taking place, but we're not testing everyone. Yeah? If we tested everyone, probably we would see more numbers. We are now doing a study in Masaka. In Chamuli, we're under the Medical Research Council, a surveillance study in a population. It's a household survey within the population in Chamuli and Lukaya. And we have already, using PCR, we have already seen a positivity rate of about 7% in this population. So you can see how the figures we're giving are a bit of an underestimate. But people are now conducting research and seeing exactly intensive research, are seeing more numbers than we're giving out. So indeed, the infections are much more. when we get the right tests for the antibodies, and these are coming, we have evaluated some, we shall be able to look at how many people have been exposed and see in the population. We shall soon have some of these figures and see what the population is. So in summary, I can say that we are testing, but it's an under, it's not the big numbers of testing because of...
Professor Kalebo, when we're starting out all these things, did we think we'll actually get to this level, or it's taken us by surprise? Did we anticipate that this day will come and we'll be overwhelmed with a pandemic?
Yeah, we used to talk about it, that if we don't have the measures, prevention measures, masks, distancing and all that, it's likely you will not be spared. Will not be spared. So we anticipated that we could come to this level. Yeah. Of course, there have been a few surprises that we need to understand. We are still thinking probably the figures that were mentioned in Africa, they have not. We don't have evidence they have reached that stage. Yeah, the predictions. Mortality has not reached the predictions as people had anticipated. So there's some belief who say probably something that in Africa that has prevented us reaching that. But where we are, we anticipated if we don't stick to our measures, we are likely, the cases are likely to rise, and we needed to avoid it.
Okay.
Yeah,
I'll get Professor Muhwezi to come into this conversation, but I have another question which I don't want to miss out, which Professor Misak, Dr. Misak will actually talk about later. And what you'll talk to me about later is the people have these issues or questions of why we quarantined them that time, why we went into the lockdown that time. They actually think the right and the best time for lockdown actually have been now, and not in April when we did it. So I think Professor Dr. Misaki will get to me to that. But let me come to Professor Muhwezi. The other comorbidity which is actually not talked about is psychosocial. Many people, when they test positive, the other problems that they also actually get, they have those stigma issues. Somebody feels maybe I might be the next person to die. Before July, when we had our index death case, we didn't fear. We knew that actually when you test positive, then you can actually recover. Ever since we got that index death, we now discover that yes, you can actually be 1 or 2 or 3 until where we are in 200, and you do not know who may be 221 or 222. Here is where we are, Professor Muhwezi. What needs to be done to the community that you actually see now, the way we are living, and what needs to be done to them, especially those who are testing positive, those who are recovering, and those who are actually having cases, fatality cases in their families. Many people feel it's actually better to deny and say, our person died, but not of COVID-19, because there's also that stigma of somebody who dies of COVID-19. How should we handle this, Professor?
Thank you very much, moderator. Denial is a very big problem. It's a disease in itself that we are having to deal with. But if I can look into what was said earlier, the whole issue of the fact that in Uganda it's not common that people know their underlying comorbidities. It's not every day that Ugandans go to a lab to test and find out what is my blood level, sugar level, what is, do I have diabetes, what. So ultimately, we don't know who is vulnerable and who is not. And that feeds into the whole issue of denial for many of our people who have now gone into thinking process that this is a mild disease. You get it, you take some dawati, and a few concoctions, and it will go away. You don't know your underlying conditions, and it could be worse. So it's something that we should, as much as possible, try to appreciate that the disease is serious, and the people whom it has taken did not know that it would take them. They did not know that it would take them. The other thing I wanted to talk about is that within our communities, there are problems that are likely to arise that are non-COVID related because of the stress that COVID has put on the resources we have. We have lost some health workers. We have a number of health workers who are not well or in isolation. That takes away our already scarce resource into the sick role. And that creates a problem. You want to access your doctor, you have an emergency, the doctor tells you, you can't see me, I'm not feeling well. So, although we are talking about the 200 and so who have died of COVID, we may end up actually having non-COVID death increasing because our health workers have become patients and have to be cared for. And so it is very, very important that we really perceive this risk and get out of the denial phase. Literally each and everybody, I think, in Uganda now knows that this disease is real. I think the denial is much more around the severity. That you'll get it, you'll stay home for 1 or 2 weeks, you'll take this and that vitamins and you'll get over it. Well, if you do, thank God. But you are not sure you will be the one who will go through that. Quite a number will not get out of that and will lose them. I think we need to perceive that.
How should people behave, especially when they get their results and they've tested positive? Because we're seeing that now in communities and places of work like here, different people are doing it. People go because they're actually wanting to travel, and they test and they're given positive results. What should they do and how should they receive this information? And actually, what do you tell them in such a scenario?
I think for those that test positive, first and foremost, they are reminded about the standard operating procedures. You have to mask. Now that you are positive, you have to mask. You have to use your mask. You have to socially distance as much as possible. You have to follow all the other standard operating procedures. You have to wash hands. You have to go with a sanitizer. You have to be careful because you can spread. You can infect others. And so for purposes of protecting the rest of the population, do this. And as you say, in very many workplaces, we have seen our colleagues testing positive. You would be shocked. You call people to say, come and help us. One of us has been having a cough. They test for the people, 6 people are positive. But these are guys who are okay. And I've had to manage a situation like that and talk to our staff, you know, go home, wait for 2 weeks, but do A, B, C, D, and follow the standard operating procedures, prevent spread of this disease beyond yourself to other people. And it has worked very well.
Okay.
Yeah.
Dr. Waingira, wouldn't we lock the country now as opposed to having done it when we did it? Because I think here is now where we're having a lot of challenges and problems, that now that COVID is actually killing people. Many people say when we locked the country, we had, I think, only about 44 cases. Only 44 cases, and of course, these were imported cases. We hadn't lost anybody, and we didn't have anybody in ICU. Now that people are on ventilators, people are dying, people are in very critical condition. We're not locking the country, and we are continuing to live normally as if nothing is with us. What would we have done better?
Well, thank you. I think that is an important question. First, we need to appreciate why we instituted the initial restriction measures and the so-called partial lockdown. That initial lockdown was majorly aimed at building capacities. COVID-19 having emerged in December, November 2019 in Wuhan, and of course started to spread across the world. WHO declaring a public health emergency of international concern around end of January 2020. We anticipated the disease would spread and come to Africa, but at the time we didn't have the specialized capacities for care for COVID-19, and we have been dealing with other pandemics, Ebola, cholera, and other epidemics that were, coming here and there, Marburg, but the specialized care we didn't have. So the initial lockdown was number one, literally try to control the importation of cases. Second reason we locked down the country was to build capacities. While people were seated at home, during the 2-3 months, we were busy trying to make sure that the laboratory capacities are built for diagnosis. The surveillance and the case finding and surveillance capacities are built. The capacity for care is built. And we made sure that we reach out to the populations and they get to know about this. Once we were confident that, yes, we have those capacities, we started to open up the country slowly by slowly. Now, yes, you would say it is appropriate to lock down the country now. Why? Because one of the reasons, the measures that we had set, or what we call a gate, was the limit of the capacities that we have. Once those capacities are exceeded, it becomes mandatory to prevent the emergence of a catastrophic situation. We need to start instituting levels of more levels of restriction. And when we started the lockdown, we made sure that the Ugandans understand this, that we had done our part as a response, and we are handing back the responsibility to the individuals to protect themselves, but also to make sure that the disease doesn't spread in such a manner that it gets out of hand and our capacities are overwhelmed. So at this point where we are, with widespread community transmission, we are doing studies trying to understand the areas where much of the transmission is coming from, and we are trying to contemplate how possibly we can introduce more measures of restriction to make sure that we can deal with the numbers that are emerging. That said, we might not go back to a bigger lockdown as happened. Why? Because the responsibility to stop the transmission of COVID-19 is upon the individuals. And the biggest thing that probably Professor Muhwezi should talk about is that we've really done a job to make sure that every Ugandan gets to hear about COVID-19 and they appreciate the risk that COVID-19 poses. So people have the knowledge. The key question we keep wondering is, why aren't the people practicing the SOPs as desired? We've thought through some of these things and said, okay, maybe people are so poor that they have to look for bread, and sometimes the priority is to look for bread rather than to live another day. But the key thing here is to appreciate that these SOPs do not necessarily stop you from going out to do the daily activities that you are supposed to do. So it is something I think Ugandans need to appreciate, that where we go tomorrow will largely depend on
how we behave today.
How we behave today.
Professor Muhwezi, that's very important. How do you feel, and what's your analysis of the communities where we are today? When you look at them, for example, they do not know, or they do not just like, I can't say they do not know, but they just don't like putting on masks the way they're supposed to put them on. The hand washing bit of it, or the culture tradition that we had adopted in the early initial stages of COVID-19 has actually now gone down. Social distancing, we've gone back to our normal ways. People have gone back to living as though COVID never came into this country. What's your feeling, and how do you look at the communities, and what would you actually have to advise? And when you see the communities themselves, how would you predict or paint a picture of the next phase of life in Uganda?
I'm very worried. I'm very worried. I was actually recently attended a function here in town, a wedding, and there are very many people. But I think we could have been, those who were putting on our masks up to the end could have been around 4 or 5. Many people had masks, but they were wearing them around the shin, like necklaces. And that really got me concerned, and I worried. And it was more or less an indoor setting of some kind. And I said, oh, Uganda, what's wrong with us? But then I remembered that in society, we have different types of people. One group which is very good, you have conformists who follow, whom you educate, health educate, or suggest anything rational and they take it up. But in society, we also have people who are rebels in thinking. They always want to go contrary to what is expected. We also have people who are always doubters and skeptical and are always questioning and want like proof, scientific proof, to be able to do what they are supposed to do. So this is the problem we have. And of course, we have those who are careless. As much as possible, we want to increase the pool of people who conform. This is life we are talking about. And so when I look at what is happening in our community, when I look at what is going on the streets, how people are carelessly, because it's not about the fact that many people don't have masks. They have masks that they are not using. Somebody is going to give you a ride on his boda. He said, "Do you have a mask?" He gets it out of the pocket. But it's not supposed to be in the pocket.
Some put them on because they are fearing there's a
or
traffic
there
man.
is a traffic police person they put on and then they remove. Some people tell you, "Oh, really, I can't breathe."
They have them in the pockets. They only come and know if you're entering a supermarket, then you'll have to put it on because you'll be denied access. Then they put it on to enter the supermarket, buy something, then again get it off.
It's a very painful situation out there. That this is a disease that we could easily defeat.
Okay.
We have been given the soaps. They work. I know one workplace in town where one of the persons tested positive, and these are gentlemen and ladies who are very, 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 very compliant with the SOPs. And they brought in a testing facility to come and test them, and all of them are negative, but one of them tested positive. And I want to suspect perhaps the masks they were using consistently helped. What would have been a very bad situation.
Okay. I'll come back to you later. Let me now go to Professor Wanyenze Roda. Let's talk about the vaccines and the options available. Because we've had the vaccine talk, Ugandans will think, yes, we are about getting there. And so pushing us so much into putting on masks and doing and observing all these SOPs when the vaccine is on its way, isn't it coming to salvage this very bad situation?
Thank you. Before I get to the vaccines, let me just add to the discussion on this. We have recently done a new projection of where we might be headed if we continue the way we are. And if we don't improve the compliance using masks, distancing, and washing hands and keeping that hygiene, we might be somewhere close to about 100,000 cases by April next year. That's what we are seeing. By
April next year?
Yes.
How many cases?
If we don't change. And we continue the way we are with crowds, you go to church without a mask, you go to the rallies, you don't do anything, we might be close to about 100,000 cases. Now, what I want to say about these numbers, Professor Ponciano said we didn't rise as high as expected. When you do these projections, you put in scenarios. If so many people wear masks, if so many people wash hands, this is where we shall be. Now, it's up to you not to prove that model right. So because of that, we also said, what would we do to actually bring that down? And we made so many scenarios. And one of the scenarios that we found which would actually help us flatten this curve without even locking down gives us about 70% of Ugandans wearing masks. If about 70% of Ugandans wore their masks properly, not putting on the chin or in the neck, covering your nose and mouth properly, and you also maintain the hygiene, and we put in conservatively, you washing your hands about 6 times a day, assuming you wash before you eat all the time and when you use the restroom, you know, basic. And then distancing, so washing about 50%. And then we had about 30% of the people distancing appropriately, that in itself would flatten the curve, actually. That we would not be rising high. And we would not even need to lock down
We'll do all those things as we continue to excel in the communities, continue working and looking for bread, as Ms. says.
Yes, we would still continue to work. So this is a situation where I say we have the tools and we can mask our way to freedom if we did the right thing. But unfortunately, we have not been able to do that. Now, let me get back to the question of the vaccine. And a vaccine is just one of the tools we would need for prevention. A vaccine will not replace a mask. It's going to take us a while before we get vaccination to a critical level that will give us the level of herd immunity within the community to spread, to stop the spread of COVID. We are all thinking we need to get to about 70% level of immunity within the community, either through natural infection, like what's going on now, or the vaccine augmenting that. But when will we get there? We've been looking at estimates.
So what does the vaccine do in this case? If
so the vaccine activates your body to produce those protective antibodies that will stop infection, you know. So it helps you to be able to build up that immunity that will fight the disease. Just like when you've been infected, you can also produce those antibodies, or you can have those cells primed that can fight so that you're able to stop, you know, that infection taking root. So when you add up that protection that you'll get from being infected by COVID, and when you add up another set of people that will be vaccinated so that it's artificially built up, then you might get to a level where you interrupt transmission. So basically, that means that you have a sufficient pool of people within the community to stop, you know, infection taking root, mixing with the vulnerables that are not immune, and then you interrupt transmission. But what does it take for us to get there? The world needs about 2 billion people vaccinated, or by 2021 is what we are looking at.
About 2 billion.
When do we actually get there? The projections for us to be able to do that, you know, they are manufacturing for all the countries around the world. So when do we actually get there? The estimate is we might get these vaccines down maybe by about May, June, and Ponciano will add to this because he's part of these discussions. But we have to live to get to the vaccine. If we continue at this pace, and if we are going to get to about 100,000 people infected by April, then so many people will not live to get the vaccine. You have to be alive to get the vaccine. That's number one.
The vaccine doesn't raise the dead. It
won't.
It only helps those who have
because when you're gone, you will not get it. Number two, even when you get the vaccine, it takes time for you for your body to build that protection. And what we are seeing now is we are estimating about 1 month that it will take. You get the first jab, you wait, and then you get another one. After 3 weeks, you get another jab, and it's only after another week that you've built that immunity. That means even when you get the vaccine, you are not protected. You have to continue to use your SOPs. You have to wear your mask, or else you'll get the infection even when you've been given the first jab. Number three, we have to factor in that it's not easy to distribute this. If we even get the first set of vaccines, you've seen how the countries around the world are rationing. They are saying we are starting with health workers, but even among health workers, you even prioritize and say the ones in ICU, the ones, you know, at the very front line. So if you even begin to ration to the health workers, when will it get to you who is banking on the vaccine? It's going to take some time. It's phased based on priorities. You come from health workers and other frontline workers. You're going to the older people. When does it get to the majority of Ugandans? What do I say? That this tool does not replace our masks, hand washing, and that in fact this mask is here to stay for quite some time, and the vaccine is not about to kick the mask off the scene. And you got to know that we don't know how long the protection from the vaccine will take at this point. We don't have enough evidence. Yeah. You're
still working on that. Thank you, Professor Roda. You asked Professor Kalebu to add on that, but also get to my question here, Professor Kalebu. What are the chances that if somebody has tested positive and recovered, that the disease can actually come back to them, they can contract the disease again? Or it is that once somebody tests positive, then they recover, then thank God they've gone through it and they are now a gone case. Talk about that.
Yeah, it's an important one. It's one of those that needs further studies. There have been a few, not many, a few cases where there has been proof of reinfection. There are not many. But we think that there's some protection when you get infected. What we don't know is how long. Again, studies have shown that it may not last so long, yeah, but we're still following. But it's because of that scientific belief that when you get infected, the majority of people will be prevented for a reinfection, at least over a particular period of time. That's the reason we believe a vaccine could offer some protection, yeah, because what happens is if somebody is infected, you get the immune response, which Professor Rhoda has mentioned, and that's what the vaccine is also trying to do. So there have been a few cases of reinfection, but there are not many.
Do we have those in Uganda? Have we had those in Uganda?
We have not confirmed any reinfection in Uganda, not to my knowledge.
Okay.
Yeah.
That's important. And you know why I started? It's because WHO says up to about 80% people contract this thing without knowing, and in a way, we actually cure from it. And that's why I'm actually asking that if you contract it, and you do not know, then you do what you do, then come over it, and what are the chances that you'll actually get back there? Now, Professor Rhoda's submission has actually worried me, Dr. Misakia, when she actually said the masks are here with us to stay. Now, there are also these feelings of the masks suffocate people, and they cause hypoxia to us, and quite a number of the things. What's the ideal time, or what's really rational that somebody can actually have a mask? I wake up at 4 o'clock in the morning, I leave my house, come and work, and I'll leave town at maybe 5 or 6 in the evening. How long am I supposed to have this mask on me? Can I put on my mask the same way I put on my necktie from morning to evening when I get back home? Or I need to find intermittent breaks when I need to put this on to avoid the issue of suffocation, hypoxia, and not having enough oxygen in myself?
Thank you. I think, you know, certainly the issue of the mask is a problem. I keep telling friends that if God wanted us to have a mask, he would have created us in such a manner that when we emerge from the womb, you have a mask with you. Unfortunately, of course, that is not it. But let's look at the scenario. Well, before you know, COVID came, the Chinese, as well as, of course, several people from Asia, because of the widespread pollution in their cities, had already, you know, adopted the concept of wearing masks. So, you know, we know COVID emerged in Wuhan in China, but you know, China is going on. Life is going on in China. Why? Because these people, it was already their culture to wear masks. And, you know, I'm pretty sure that many people saw Chinese come here, you know, putting on masks, and you ask yourself, why is somebody wearing a mask? Is it because they imagine that Africa is too dirty? But, you know, it's just that this was a way of living that the Chinese had adopted. And unfortunately, that is where we are now, in the sense that we've come to a point where we must also adapt to wear masks more frequently. Now, the issue of suffocation, there are different types of masks. And most important thing is you could look out for the types of masks. I always advise people that the surgical mask that I'm wearing is not as heavy as a cotton mask. Neither is it as heavy as an N95 mask. The N95 masks are designated specifically for the doctors that are working in the ICU, and but those are, you know, extremely very efficient, but at the same time they have challenges. So I think the key thing is look out for the mask that works for you, number one. Number two, do not exercise with a mask. If you are going out, you are in an open setting, you are by yourself, get the chance to get off the mask. If you are within a setting where you are alone, you don't have people around you, you can always have the mask off. So those breaks are necessary. The other thing, of course, to really try to think about this is we have so many people making masks out there.
In every kind of material.
In all kinds of material. The most important thing is the reason government of Uganda gave out those masks that are labeled government of Uganda is because we requested the NDA to make sure that those masks are certified for the purpose of preventing COVID-19. So that is another challenge that we have as far as masks are concerned. But regardless of the challenges, the discomfort that comes with this, it's important that people know this is a lifestyle that, not a lifestyle, it's a necessary change that we need to adapt. The same time, of course, we need to realize that people who have respiratory illnesses might not need to wear the masks. Very young people under 6 years, it is a problem for them to breathe with these masks. So you need to give the allowance that the underage and below 6 should not wear the masks.
Okay.
Yeah, so, but this is supposed to be here with us.
Okay.
Yeah.
Well, that's very important. Professor Kalevo, let me come to you on this particular one. Now, you gave us, we heard from you, the scientists, of course, and told us the phases, phase 1, 2, 3, and we are now at phase 4, where we're trying to manage COVID in the community. However, we also hear about something called the second wave. Now, is Uganda yet there, or we can avoid that, or we will definitely have to get there? I do not know. Are we past level 4 and into the second phase, or is level 4 the second phase, or we are not yet there? We need to know what second phase entails and what it means, and now we need to brace ourselves for that particular phase.
Okay, maybe understanding the waves, it's a simple seeing the cases coming up when they were coming up in some of the countries, then measures were taken, then there was some uneasing of locking, then you see cases coming up again. So you see a rise, a fall, a rise. And people predicted in those countries, Europe and USA, that they could have a second wave due to a number of reasons, including some of them they predicted if the cold weather comes up again and people are indoors, we could see that again and others. But here in Uganda, I don't think we have gone into the second wave. Probably we are still in our, as Professor Roda mentioned, I think we started seeing a real rise in August going up. Yeah. Now we are still in that rise up. Yeah. We have not seen, I hope we shall see cases coming down. I hope we don't see another rise again. So I think we had that rise, they're coming up. Peaking. We don't know where the peak will go. She says the peak is facing the roof. So we are not, here in Uganda, we cannot describe that we're in a second wave. Yeah, the cases are rising. Probably we're in our first, part of the first wave going up. Yeah.
All African countries that have gone through elections this year, and we talk about close to 22, 23, 24 countries that have had elections this year, from when we had Corona come into the continent. Now that's about the month of February to date. Uganda is also into that very phase and will have an election next year. And we've seen that in many countries where they've had elections, they've had actually an upsurge of the infections. I need your prediction as scientists, because you need to highlight to us the problem. You are where we are not. You are in the hospitals, you are in these health facilities, you know what is actually happening there. We need to know, looking at the situation today, because when you talk about it, it now becomes also a political thing. You do not want us to do this because you are afraid of this. You are using COVID-19 to actually curtail our freedoms and do all the things. Project to us, politics does not concern you, even when it manages society where you are. Give us a picture of what we anticipate, especially after January next year when we go through the elections. Professor Roda.
We did the projections that I've just mentioned, factoring in a lot of this excessive movement. And if we don't do anything about it, this is partly what contributes to that huge number. And this is coming, certainly elections, it's a big thing. We've all seen the crowds. We've seen people are squeezed together. We've seen the masks are not there. And because of this is actually contributing partly already to the rise. Because when you look at that curve that I was describing to you, and then you ask yourself, what changed? Because the curve is only telling you where the numbers are based on what you are doing. And what we are doing, you can actually see what happened in August, because you see August, mid-August is when we begin to have this rise. What happened a few weeks before August? And you can superimpose our activities on that. What happens now in September when we begin to shoot up and we continue up? There's a lot of things happening. Elections are one of them, certainly, the huge crowds. But there are other things also going on alongside the elections. The weddings have become bigger. They are now in hundreds.
Funerals, church services.
Exactly, they are now in hundreds. The funerals are now in hundreds, and others are pulling 1,000. We are back to feeling great.
We are back to the normal days.
You have many people at a funeral. So these are also happening alongside the elections. And now we have a big threat of the Christmas and New Year is coming. People are going to descend on the villages. So all these things are happening alongside the elections. And because of that, we are certainly just going to go up, because we are already on the rise. And I don't see us coming down. And I don't think we've peaked yet, given the activities that are going on. We are continuing on the rise. And this rise, if you just think about 3 days ago when we got more than 1,000 cases in a day, Uganda moved from being among the best performing to the third worst in cases per day in Africa.
From the best performing?
Just second to Morocco and South Africa. We went past Ethiopia, we went past Kenya.
Even
we went
past Kenya, actually.
Past, in that single day. And if we continue, I think we will be threatening going past Morocco one of these days. So all that is happening because of the activity. Elections are part of it, top of the list, the weddings, the funerals, the parties. People are now doing birthday parties in the homes and calling their siblings, your sisters and brothers, and when they are together, you feel safe. All that is happening, you know. The markets have gone back. It's no longer what it used to be. So we have all this activity, and what this curve is telling us is we are doing certain things wrong, and those are the things. And the worst of all, we continue to use masks as a fashion accessory. It's like a scarf now. They've become really nice and flowery, and you can match it and put it in your neck. And sometimes we pull it down. I feel so sad when I see people do that. Your neck is exposed and speaking everything. You pull down your mask.
Then when you see a police officer, you bring it back
You
up.
bring it back with all the germs that it has picked from your neck, and you put them on your nose and on your mouth. So you're basically picking the COVID if it was in the neck and putting it back on your mouth. If you want to put down your mask, if you are in a place that is safe, like Misaki explained, clean your hands, sanitize if you have one, then hold here and remove it nicely, and then keep it. And then you can use it again, but don't pull it into your chin, your neck. So we are doing all these things, and then everything is wrong.
Okay.
And so because of that, we are not even tipping yet.
Mr. You wanted to add something on what Professor Roda said.
Well, I think Professor Roda has just done a good job to tell you how, you know, the elections are part of so many activities that have subsequently led to the rise in numbers. But of course, you know, one of the things to appreciate is that a lot of these things assailed the process of opening up, easing the restrictions. And in anticipation, of course, the key thing here was that we've told Ugandans enough. Ugandans know what to do. So we have to, you know, ease the process and make sure that people... But when you look at what is happening, particularly these crowds with the elections, is extremely unfortunate, including people who are supposed to be leaders, you know, putting their lives at stake out there. And sometimes I keep asking myself, so when this person falls ill and ends up in ICU, what are they going to do? You know, gets to pass on. So I think that, you know, if we aspire for leadership, it is important that we get to appreciate that the leadership that we seek, you know, to provide starts now when you're campaigning for the leadership. So it's unfortunate that you can take a selfie with crowds of people not wearing masks. You know, these are extremely dangerous times, and I really, that's what I really wanted to add onto this. When we come from the setting of the health facilities that we built, what we call the COVID treatment units, I'll tell you, the high dependence area where we give people oxygen with the nasal whatevers and the masks are full. Our ICUs are full. So if you look at what happened in Europe, places like Spain, when the numbers of deaths began to rise to have 800, 1,000. The US yesterday lost 3,700 people in one day. This happens when people who fall ill or get infected and suddenly need support come to the health setting and there is nowhere to place them. Now, we are at that point, and I think Ugandans, sometimes I have told people that Ugandans behave as though they have the best health system on the planet, better than that of the US, better than that of the UK. I'll tell you, if you know that our health system is limited, by the way, in many ways, because the strongest anchor that our health system has is committed health workers. But I'll tell you, we have had over 1,000 health workers infected. And we've lost so far 14 health workers. This week alone, the week that came through, we lost 2 health workers, very senior health workers, the DHO, and so the public has the responsibility.
The of Chiboga.
Chiboga. The public has the responsibility to protect the health workers. This country has a very large population to health worker ratio. I think between 1 to 25,000. So we have very few health workers, and particularly when it comes to those that are trained and specialize in caring for COVID. So it is important, number one, we protect in whatever setting, whether it is in non-COVID settings for health workers or within the COVID settings. One of the things we found is that most of our health workers actually probably pick this infection in the non-COVID setting because there is a lot of compliance and restriction, measures that are SOPs to prevent the exposure in the setting of a COVID treatment unit. But you picture yourself, this health worker seeing you in an outpatient clinic, and you're coming in with a fever, thinks it's malaria, you know. And unfortunately, the initial signs of COVID sometimes are like that. You get the fever, you get the weakness, and you run to this health worker in his small clinic, and you're not wearing a mask. So we need to appreciate that, number one, it's our responsibility to protect the health workers. Number two, it is our responsibility to make sure that we maintain the gating system. We reduce the rate at which the numbers of cases are emerging that need hospitalization. Remember, we are only hospitalizing symptomatic cases. The asymptomatic cases, we ask them to go home because we don't have that capacity to hold the asymptomatic cases. But if I tell you that we are overwhelmed, it means that we are having more people who have symptoms coming up. And the most important thing is to make sure that those people coming and they have symptoms, they require care, do not overwhelm the system, because that's when we will have so many deaths.
Okay. We'll talk about the home-based care, which I think is another way to go now. But I want all of you to attempt this question now. It really doesn't concern you as scientists. But this is what is in the community. The people out there think you are exaggerating these numbers because it's a political season. And many think that after the elections, we'll see us now flattening the curve. You are giving us these numbers simply maybe because you want to scare away people or to do all the things. Now, it doesn't really concern you as politicians. You are scientists. But yes, what you have to tell the people, all of you now, I will start with you, Professor Mohwez. These numbers are rising because they have a political message in them. You want to scare us, and we assure that after 14th January, then we'll see the curve again flattening and coming down maybe.
For starters, the coronavirus is a highly infectious
and virus. It is with us. We're not doubting any longer.
There is nothing political about it. Whether you are a president or a mayor or an MP or an RDC or a person with a disability on the street, as long as it gets space, it will get to you. So there is nothing political about this. The numbers, good enough, by the way. These statistics we are having, by and large, are so listed. People get out of the way and approach testing centers. So you cannot say they are manufactured. Professor Karebo has not gone out on the street to test people. People are coming. And that's why we are saying the message they portray is not the total picture. Because people come up, they invite the people to test them at their places of work in different organizations, and then we get these statistics. I think we should look at that picture and know that the COVID situation is worse than what we see in the numbers. There are very many people who are positive, maybe good enough, many are asymptomatic, but there are very many. And they are spreading. That's what worries me, is that even when one is asymptomatic, they spread this virus. So in whichever situation, yesterday I watched a clip of a very popular religious leader, and he was telling his COVID story. And he started by attempting to describe he got it. The summary of it was that he didn't know how he got it, but he got it anyway. So any of us can get it, or will get it. We don't know whether we shall be asymptomatic or not. So there is nothing political about it.
Professor Karebo.
Yeah, I think just to add, I totally agree. There's nothing political. We are providing information as people see it. The good thing, even when I talk to some of the people I meet in the communities, they're beginning to realize, because at least most people know somebody somewhere who has got it, who has tested positive, and some who have unfortunately passed away. Definitely mixing politics with health is not a new thing. We just need to educate people. Like me as a scientist, in all my life, I've never been mixed in politics as I've been mixed with COVID. even on talk shows on television, some people even were mentioning my name for the first time in the politics, inflating things, prices, and all that. So then it is only this time that I sympathize sometimes with the politicians. Yes. That probably sometimes what we hear is not necessarily correct. Sometimes I've also blamed the politicians, but at least I've learned also that when you are really at this critical time, when it comes, especially at the time of elections, then things get mixed up. But I assure you that the people seated here, they are really scientists. We are scientists, we are not politicians, and we are trying to protect our population. We are trained as doctors. We took the Hippocratic Oath. We are managing our brothers and sisters in the country. We have done it for years, for HIV, for other infections, cancers. COVID is not the first. I don't know why COVID, we should cook data just for politics, just for COVID. Personally, I don't benefit. I will not benefit anything in this. So people have to believe us. The COVID is not only in Uganda, it's in other places. But I think they're beginning, I realize people are beginning to say, oh, In fact, I'm the one now reassuring some of the people to calm down a little bit. So this is not politics, this is real.
Would you advise the Minister of Health to allow for, I do not want to call it exposure, but to allow for a situation where we can actually have what is happening in hospitals? For example, you have the privacy bit of it, where if somebody is sick, and that's what they are. When COVID just came into the country here in the month of March, April, May, we were getting pictures and footage from the UK, from everywhere, and that scared, that caused the scare. People stayed in their homes very comfortably because they knew what was happening elsewhere in the world. Now that the situation in Uganda is simply just narrated or talked about, and nobody ever sees what is actually happening in these facilities. When Dr. Misakia says our ICUs are full, our HDUs are full, our centers are actually badly off, terrible, it's swearing us, and we're just narrating them, talking about them here. Would you advise, because of course you the doctors will say it is privacy, nobody would love to have such a picture, but we saw it in Brazil, we saw it elsewhere, and that's how we actually managed to get into the houses to actually keep for that time to manage and to prepare ourselves. Would you advise that health actually goes ahead to project, to show, to let these come to the people, to breach the privacy for us to know how bad the situation is? I'll still get back to you, Professor Kalebu, before Professor Rhoda attempts it.
I think you raised an important thing, and you had me nodding. Many times it's after people seeing. It changes a lot. For HIV, we saw it. When people were seeing, people were slim, dying, it really changed. Initially, people had not seen HIV/AIDS, and they didn't. But when they started seeing, the pictures you mentioned early in the year scared people, yeah, were full. Probably you can do it. You just have to, you don't show the face, yeah. You can hide the face, but somehow show the picture. Unless my colleagues say otherwise, I would favor what you are saying. Probably people need to see than Misaki talking, we are full, we are full.
HD is full, IC is full. People don't know what IC, what it means for the IC to be full.
Yes, I think so.
And you know why? It's because in the early stages, when people were coming and getting quarantined, we could see people doing selfies of saying, look at us, we're in the hospital. Now what's wrong with me? I'm not sneezing, there's no flu with me. I am here, we're eating, they're only giving us this, a few Panados and stuff like that. And you know, these videos could actually circulate on phones and everywhere. And everybody was like, oh, then if they tested positive, what's the problem with them? But the pictures that were coming from the rest of the world, they actually scared us and saying, yes, here is where it is. There were lots of conspiracies. Professor Rhoda, you seem to agree with that.
Yes, I do agree. I think people need to see what is happening in there, but we have to do it ethically and professionally. There might be people who are sick who actually want to tell their story, and we've seen some of these videos where someone says, I don't want this to happen to somebody else, and I need to share my story. Why should we stop them? If they can share this story, we need to see the other side of the coin. And also, if there is a way it can be shown, like Professor Kalebu said, without necessarily violating the privacy, why not? We need to see if it's going to help. Recently, I saw this on CNN, and they actually had to put a disclaimer and explain and say, you know, we didn't want to do this, but we think it's important. So I think we are headed there, where we need to open up. Those who can tell their story can tell it, and we can show what is really going on.
You all seem to agree with that, Professor Muhwezi. You are in agreement.
Yes.
See, I think, you know, at the time, one of the most scary thing was to see, you know, the digging of mass graves in New York, you know, and Brazil, and that might...
And in Italy.
And Italy. And that, you see, the way our society is arranged, that might not happen in Uganda. Why? Because we still bury our own dead. You know, we seek out the dead. We know a relative will always show up and say, this is my relative, I have to take them for burial. But I can assure you that the frequency of picking up the dead from the morgues is going to increase. If anything, I joked with Dr. Ayen, the director for KCCA, if anything, this was the time for him to make sure he's digging graves in his burial, his burial sites. Good luck for us, we don't, our culture is that we bury our dead. So, but the frequency might increase. So, but yes, certainly, this is something that can be done. Key question is this the best method really to communicate, to bridge the gap between what people know and what people practice? And this is exactly what you keep asking yourself. How do you make sure that you enable people to transition to practicing without necessarily having to scare them? You see, the African saying are quite many, talking about, you know, people who hear and choose not to do, but the people who hear and choose to practice, sometimes the so-called cold coward lives longer, you know. So I think the key thing here is that principle. Should it take scaring somebody to practice this? We were lucky, like Professor Pontiano has said, in the instance of, in the case of HIV, and we had several of our prominent people, including the late Fidel Rutaya, come out, and you know, there's the video that UBC used to run, literally, and was, you would see Fidel Rutaya's life. And
on your TV?
Yes, and through hospital. And so, but it's possible. And the funny thing about, by the way, and this is one thing we need to demystify, when we, at the point of importation of disease, we had lockdown. So the people who are active, moving up and down, the truck drivers, this is why mainly young people, you know, very healthy, many of them without comorbidities, and that is why we saw those dancing patients in there. But now that the disease is widely spread in the community, it's beginning to reach the vulnerable groups. These are the people that get severe COVID. The other thing I need to tell people is that when it comes to COVID, the transition, naturally, the oxygen levels in your blood need to be above 95.
Oxygen levels.
So the transition to below 95, falling to levels where you need to be on oxygen, happens so fast. It can happen within 30 minutes. So you can find a COVID patient busy, you know, SMSing here on the phone, and then the next day, next few hours, either these people are dead if they don't receive the intensive care that they need, or you find that they have fallen. Yes, it happens so fast. The transition happens so fast. And that's why we are advising, even in the setting of home care, that people need to have pulse oximeters. These can be procured. They are mobile pulse oximeters. You need to measure your oxygen levels. When the oxygen levels begin to fall below 95, you need to reach out to your physician so that we begin to see what options are available for you. Unfortunately, by the time this falls below 50, there is already damage taking place to other organs. The brain is not receiving enough oxygen, other organs are not receiving enough oxygen. So even if you are able to pull through, there is extensive damage that has been done.
How about somebody finding hydrogen peroxide, having that as, I do not know. I am now asking as a journalist, how about having hydrogen peroxide to help on the oxygen? Because yes, one of the reasons why people's hearts actually fail is because they do not have enough oxygen in them, and this is actually what is happening with COVID itself.
So hydrogen peroxide as a potential source of oxygen, because this is this is chemistry now, the basic chemistry, senior 2 chemistry,
which I think
literally synthesizing oxygen, and there are different ways. But here's the thing, is yes, we have different plants producing oxygen through different methods. Some of them use sulfuric acid attached to metals. Other approaches for producing oxygen come through. You don't need to do this crudely. I mean, I'm not sure how the crude thing would work out for a living being. But The most important thing is literally to reach out to a treatment center which has the purified oxygen.
So exactly, which is now the best way of actually having enough oxygen? In such a situation, we now have the oxygen where we are here, but we're looking at that situation where you just narrated or just painted a picture to us that this patient is actually texting and maybe chatting with a friend, and the next few hours, they have the oxygen levels have actually gone down.
Yes.
Which would be the best or easiest remedy?
So they
for
need
us
to be.
increase
They
on
need.
the
They
oxygen
need to
itself.
be. They need to be in a. They need to first of all be able to detect that fall in the reduced oxygen levels in the blood, and they need to reach out to a center which can then offer them oxygen externally, either through the prongs or the mask, which we could. That is high pressurized oxygen. That is what we define as the high dependence unit. You are in there. In the high dependence unit, you will still find patients on their phones, you know, texting, but they're on oxygen. You pull him off the oxygen, they go down, you know. And that's exactly what happens. And unfortunately, even in there, you still find patients who will still go down, and they will require to be put intubated and put on a mechanical ventilator.
How long does it take for somebody to be put on oxygen to actually resuscitate and come back?
Well, you know, the issue of ventilation is another thing. I mean, even without COVID, you don't go into an intensive care unit and expect to get out in a week or two. It's actually a process of healing.
Because
by the time you get there, usually, you know, so many things have taken place, and you will find that when people get into ICU, the minimum they can stay is a week or 2 weeks, and it's usually protracted, and so it's a problem. But the key thing is, number one, get to detect and go to the hospital.
Okay,
yes.
Very important. Thank you so much. Before I come to you, Professor Mohwezi, on the home-based care, somebody has just sent me a message here to say what you just asked about this, what you just asked the scientists about to see what is actually happening in hospitals, will show tonight on UBC TV and on NTV because they've been given access to the hospital ICUs to actually show. And so I'm actually very grateful that, yes, UBC TV, NTV will actually be able to let the world, let the public know what is actually happening. Maybe that will also help change and shape the perception of what is actually happening in our hospitals. Let's talk about the home-based care because our time is running out, and we just have about 15 minutes to wrap it up. Professor Mohwezi, the home-based care, the challenges here are that somebody goes to Professor Kalebu, they test and they're given their positive results, and you tell them, go home and isolate. Now you're telling somebody to go home and isolate. This agenda is in a house where you have one room with a wife and maybe 2-3 children. So I am must actually go and isolate. The next question is, am I going to church to sleep at church? Should I go to, where do I go? How do I isolate? It's home-based care. The hospitals are flooded and I can't get there, but I've tested positive. I need to protect my children, my wife, my people in the house, but yet again, I do not have enough space for that kind of isolation. How are we going to manage the home-based? Because I think it's another way to go, but with also its own eminent challenges.
Thank you very much, Jaged. That's a very difficult question. And the people who worked through the documentation to advise for home-based care must have thought through all this, because you have just described what is typically Ugandan homestead, average homestead. It's a very big problem, lots of congestion, lack of space, especially in urban in our urban enclaves. Perhaps in rural areas it could be a little bit different. So it's a very big problem. For me, my best shot would be, let us not put ourselves in a situation where we are going to be told to go home when you have no home to isolate in. Because quite frankly, if the hospitals, the ICUs, the waiting areas are full, the high dependency unit is full, the more reason you should literally
protect yourself
and get hold of these SOPs and say, this is my salvation. Because beyond this, when you tell me home-based care, you're actually sending me to infect my people at home, and it will be as they say, a mixed salad, katong of some kind.
It will become a catalog of sorts.
Yeah.
It's unfortunate that
unfortunate,
Dr. Ateka Jirita did not get to studios to us, because I also wanted him to paint to us a picture of the epicenters in Uganda, for example, the instances themselves, and where we have the biggest challenges for people to actually know. Professor Kalebu here talked about a study that is being carried out in Chanamkaka in Masaka. And Chamliwa, not Chanamkaka, in Chamliwa actually, Chamliwa and Lukaya. We really needed to know, or to have the broader picture of what is actually happening in the different areas out there. But because our time is running out, we are going into Christmas and of course the end of your festivities. Now we're going to have a Christmas this time round where there is no Evivuru as we are normally accustomed to that, because we would have now started the Christmas fete. We are in this Christmas where we will do things, of course, in hiding. We will drink in hiding. We will, I think, also try dancing in hiding. We will try to find ways of doing these things, of course, not the conventional way. But please, give us now advice. Help us. How should we fare through Christmas? We are used to Christmas moving from Kampala to Kabohe, and that's how we enjoy our Christmas. Many of us spend the whole year in town working, and you wait and say, when it comes to December, I'll go to Mbale, I'll go to Tororo, I'll go to Kabale, I'll go to celebrate Christmas. You are advising against that. Just help us. How should we manage this period, and how should we go through the Christmas festivities where we'll not have the traditional and usual ways of celebrations? Rhoda.
I would say, for me, the first thing about Christmas is let's live to have another Christmas next year. Because honestly, you might want this Christmas so much that it might be your last, if you're among the few that will get severe disease and not make it. Or you will make it, but your loved one will not make it because you have transmitted infection to them. Really, for example, I have been missing my dad. I would love to go and see him. But honestly, the best I'm going to do, and I have been sharing this openly, that I will go there, I will sit with him, and we shall share at a distance, and I will have my mask and he will have his, and I will return to Kampala. I will not even stay in his house. That's what I'm planning to do. I don't know what others want to do that will work for them. But he will be at a distance. I'll wear my mask. I'll talk to him so that he sees me and I see him. And I will come back. I will not sleep in his house. Because I don't know how I can manage staying there and also protect him. Because I've been away and I've been engaging in several things. And the old man is seated in the village. Yes, he is.
He's seated in the village. He's not
in
loitering around.
Yes. I will go there. I will not sleep there. That's what I'm planning to do. I don't know what others are planning because each of us needs our plan. Because I want him to be there and I see him next year. But also, if you want to have this party so much, so that your party then becomes a problem, you know, we were reading this story of this wedding. It might not have been in Uganda, it was in the US, but where 7 people have died who did not even attend it because those who attended took the infection to those people. And we don't know, we haven't even tracked well enough to see, but we are already seeing clusters of people who have been at a funeral. I was talking to someone about a funeral where 9 people have now tested positive. But we don't know how those 9 people will fare and how many more could have tested positive, except that we didn't get them. So Christmas, my first advice is please live to have another Christmas so that you can celebrate maybe twice or thrice, but at least be there to celebrate it. Find a creative way of seeing your loved ones without necessarily putting them at risk or putting yourself at risk. Please don't lock yourself up to dance. If you live to next year, maybe when we have the vaccine and we keep building up, maybe we shall find another way of dancing.
Of celebrating, dancing.
And we shall celebrate. So let's be creative within the SOPs. If you lock yourself out, COVID will out you. The curve goes and it doesn't lie. Yeah.
Professor Pontiano, I will not also shy away from asking this question that our neighbors in Tanzania, at my very good friend Dr. Pombe Magufuli, people are actually saying the last time they released their results was, I think, in April, on the 29th of April, where they only showed about 29 deaths at the time and 509 cases. That is what has remained on the dashboard forever. And people are saying, yes, if the problem is this very bad, why isn't it happening in Tanzania? People are not dying in Tanzania. And actually, people think or feel you rather escape out of Uganda, possibly go to Tanzania, dance, celebrate, do all the things. If you have relatives in there, then they come back to Uganda. Let's, just in passing, because I can't let you go without talking about the Tanzanian situation. If it's that very bad in Uganda.
Everywhere I go, I anticipate that question.
The Tanzanian question.
The Tanzanian question. The Tanzanian question. They say, but how about Tanzania? We did this, but how about Tanzania? The fact is that we don't know much what is going on in Tanzania. I have colleagues working there, scientists, researchers, and we exchange some of the studies they can't do to really get the real picture of what they have. So that's on one side. They say, we don't have the real picture. On the other side, some of them are saying, some of the hospitals, we are not seeing the overwhelming cases as we should have anticipated. But still, there's a gap there. They don't know what is happening. A lot of the information is not being collected in the communities. So there's Tanzania, there's a lot unknown. But the fact is that the disease is there. We saw the truck drivers. Oh, if the truck drivers coming from Tanzania were testing, they were positive. Yeah? And the disease is there. You just need to know if we have the same picture of the disease, if they're not taking preventive measures, it is spreading. And if it's spreading and they have big numbers, then you expect a few cases to have, a few individuals to have severe COVID and death. So Tanzania, the picture is not very clear, but from the little information we have at the border, what we saw at the border, there's high infection rates there. It's not that they don't have the COVID.
Okay. Well, I thank you so much. Your Christmas message?
My Christmas message, start tuning your mind. Start tuning your mind and be consoled. Those who have televisions, they have watched others. In USA, they went through the Thanksgiving, stay at home. In Europe, everyone they're saying stay at home. I think start changing your psychological and say, enjoy your Christmas with the few people you have. Okay. And you UBC people and the NTV, please entertain us. Give us some nice programs on TV, and we shall enjoy at home.
Okay. Yeah. Well, thank you so much. Professor Muhwezi.
I think my parting shot is that let us be faithful to the standard operating procedures. For those who must go, Rhoda has told us she has to go and see her dad, SOPs. SOPs ensure that you adhere and observe them to the letter. But as much as possible, if it is possible, let us stay where we are.
Okay. Yeah. Well, thank you so much. And finally from you, Dr. Misaki.
Professor Rhoda is able to go to the village.
In Bulambuli?
In Bulambuli, because Professor Rhoda has a private car. Professor Rhoda, there are many Ugandans in Kampala who will
not drive to Bulambuli back and forth. You can drive to Bulambuli, have lunch, and come
onto the buses, and of course the taxis in a very full manner and head out there. I think the security, the defense team was here and actually literally tried to warn people about the situation. The movements, one of the things we've said is COVID-19 is a disease of urbanity and globalization. The quicker people move, if you see countries, Europe got first hit because European gets on a plane, today they are in one place, the other day they're in another place. And trust me, these movements will literally make the disease penetrate heavily down there. Second thing to say is, I have not seen you know, we keep joking every time we have our meetings, especially the physical meetings, is that this virus must be very smart. Because when it comes to time for food, no one eats through a mask, isn't it? Eh? We all put away our masks. Professor Rhoda will tell you that the people who have contracted COVID many times have been with the people, either they are friends, either they are relatives. And in your mind, you imagine these people, they are safe. But unfortunately, and that's when you put down your guards, you know. And so, you know, it's a very difficult thing. And if possible, Professor Rhoda has told you the concepts of us taking the responsibility to protect our vulnerable parents, our vulnerable elderlies. But also the most important thing to realize is that if you have not been with somebody, you don't live with somebody, you need to be careful, even if they are your friends, you know. They are your relatives. You're going to meet them, most likely you're going to put down your guards, and that's where you will get unlucky. So we actually need to be very careful.
Okay. Well, I want to thank you so much, ladies and gentlemen, Professor Rhoda Wanyenze from the School of Public Health in Makerere University. Thank you so much for having allowed your time to be here with us, and of course to give us your side of this story of COVID-19, and of course sharing with us on the current situation. Thank you so much, Professor Pontiano Karebo from the UVRI in Entebbe. We also thank you so much. You're doing a very good job there testing, and we pray that maybe someday you'll actually get there where all Ugandans can actually be tested. I think this has happened in Taiwan. We heard that the last time I checked, I think on the 29th of October, Taiwan had actually tested everybody, and for 200 days they had not had a community transmission in there, and so life is normal to them because they're now actually guarding against who comes into them, but they are sure that when you move into the Abulambuli and their Chamlibwa and all these other things in Taiwan, you can actually manage it. So we are hoping for that time when we'll be able to actually test and all of us know the situation. Professor Muhwezi, I also thank you so much for having allowed to join us here, for sparing time today, and of course to the chairperson, Dr. Misaki Wayengera. Thank you so much also for leading the team and for the job that you're doing. Unfortunately, we couldn't have with us in studios Dr. Tek Jirita, the Deputy Incident Commander, who was supposed to be with us to also tell us and highlight to us a few things here and there. But nonetheless, we've managed to go through this, and we just want to appreciate all of you who have been part of the discussion and conversation here on UBC TV. My name is Jagenda Semakola Ziksoka, thanking all the team that we've done this together with, especially my floor managers, the camera persons in here, and of course all the people behind the curtains for making this possible to us. A very blessed weekend and a good evening from me to you as we continue inspiring Uganda for God and my country. Wear your mask, stay safe, and God bless you. Thank you very much.
Thank you, sir.
Double data. Airtel introduces double data, the biggest deal ever on smartphones in Uganda. Buy a smartphone, 3G or 4G, and get 100% data bonus from Airtel. Airtel is giving you 100% bonus data on all weekly and monthly bundles for every new smartphone connected to Airtel for the first 3 months. Dial *175*9# to enjoy double data. Double data, double data. Oh, bino bye biruma abayaye. Airtel, the smartphone network, regulated by Uganda Communications Commission.
Bro, what's up? How are you, Golden?
I'm good, bro. Long time.
Yeah, it's been a minute, bro.
Man, it seems this dancing thing is working for you proper.
Wow, man, you know the hustle.
Struggle, I feel you, bro. Assuming we're about the election drama, who are you voting for president?
Yo, bro, you know I hate to talk about